Okay, right. So it is 1 minute past 1, so time to get cracking. Welcome to Grand Rounds. My name's Tom Fardner. I'm the chairman organiser of Grand Rounds, along with Colin Fleming, one of the operational medical director. And one of the great things I think about Grand Rounds is the wide range of topics that we have. We're able to keep up to date and try to be as topical as we can in terms of COVID, and last week with our Black Lives Matter focused Grand Rounds. But we're also able to afford opportunities for people to talk about things that perhaps you wouldn't think of as being a topic for Grand Rounds, but actually turned out to be very interesting indeed. And Matthew Checketts, who's one of our anaesthetists here in Tayside, contacted me a number of months ago, pre-COVID, to ask if he could present on his experiences of taking a sabbatical and advice about how you might optimize your sabbatical if you do take one. Now, it's something that I haven't really thought about at all. So I'm really looking forward to finding out what he's got to say. If you have any questions during the talk, please just send me a message through the chat system and I'll be able to direct the questions to Matthew at the end. Otherwise, we'll just hand straight over. Thanks, Matthew.
Thanks, Tom, and thanks for the opportunity to speak today. My sabbatical was last summer. It seems like a lifetime ago away, since all the things have happened since then. But I'll tell you about how I conceived it, how I set it up, and what I did on my travels. I've got a lot of information which I'm going to share with you. A lot of the detail on the slides, we won't have time to go into a lot of detail. So if you're interested, you can always watch that with the pause button on the rerun. But before I get into my day job, I want to tell you about my new lockdown job, which has been a bit of fun since I had a bit more time on my hands with lockdown, which is making radio shows. And I've got a new radio show on Mixcloud called Heaven's Mixtape. So if you like music and you like a bit of chatting between the records, go to mixcloud.com, Matthew Checketts, and you can hear my first 3 episodes. The 4th one's coming on this weekend. So that's just a little shameless plug. Anyway, back to sabbatical. Why did I do a sabbatical? Well, I was leading the tech project in Dundee, and I'm sorry to say that was the Dundee end of it was cancelled by the chief executive at that time. And not to put too fine a point on it, I hope I don't upset anybody, I was a little bit disillusioned with NHS Tayside and my professional life at that time. So I considered my options, and one of the things that popped into my head, I remembered from the consultant contract, which the BMA negotiated, that there were opportunities for consultants to take clinical sabbaticals. So I thought this was a chance to do something different and for some personal and professional development. And I thought the experience I might get on my travels would hopefully be of use to NHS Tayside in the future. Interestingly, when I went to look at it, NHS Tayside did not have a consultant sabbatical policy. This is the section of the consultant contract that talks about consultant sabbaticals, section 7.4. Clear benefits for the individual, enabling a period of development and refreshment, to use a leave in the furtherance of a project that's in the interests of the NHS and contributes to his/her continuing professional, clinical, or leadership development. So you can read that in your own contract. What are the factors that determine if you might be eligible for this? Well, as I said, that what you're proposing to do needs to be in the interest of the trust. You need to have a certain number of years of service, so you're entitled to apply for up to 6 weeks leave after 7 years as a consultant, and after 10 years service, you can apply for up to 3 months leave, and that is potentially paid leave. If you want additional unpaid leave for other projects, you can seek that as well. If it's approved, the good news is that all your employment terms and conditions are preserved, your pension and so on. You need to apply at least 6 months before you plan to go away. And you need to say on that application form how the leave will be used. You need to give quite a detailed itinerary of what you're going to be doing and what your objectives are and what the specific benefits might be to the trust and to yourself. You need to consider what cover arrangements might be required for your job when you're away, and you obviously need to negotiate that with your own department and colleagues. And you need to consider what expenses you might incur on your travels, and payment of expenses by the trust is something that is discretionary. There may also be third-party payments that you may attract, as I did, because I worked as a locum consultant in some of these UK centres. So that needs to be ironed out. The way we ironed it out, of course, was to ask the trusts who were paying for my services to pay NHS Tayside directly, and I just got paid my normal salary from NHS Tayside. So I did a bit of Googling, and quite a number of trusts in Scotland do have consultant sabbatical policies, NHS Fife, for example, NHS Lothian, and I found an application form on Greater Glasgow and Clyde website, which I doctored and filled it in after considering what I might want to do. Now, I'll tell you the specifics of what I did shortly, but I wanted a kind of portfolio sabbatical, so I'd visit quite a number of different centres, both in the UK, the USA, and Europe, because I thought I'm only going to get one chance to do this. You might as well make it as interesting and as varied as you possibly can. I spoke to the clinical director and Colin Fleming, the AMDs on the line, who I'm glad to say were very supportive. And then there was a series of complex arrangements that had to be made with all the places I was visiting. For example, if I'm going to be working there, I had to go through a PVG and an induction process. In the US centres, there's quite a lot of paperwork to complete, particularly for a place like Duke Medical Centre, which I visited. The Danes, when I went to Copenhagen, were somewhat more relaxed. But it takes a lot of planning, but the persistence paid off. Some of the places I visited, I had already had friends or contacts there. Some of the other places I didn't. And I just kind of doorstepped them by email. And if they didn't reply, I was persistent. So I think persistence and politeness usually pays off, because most places are quite flattered if you want to go and visit, because you're going because they're centres of excellence. My objectives, as you see on the screen, these were centres that I knew about, either from personal experience, colleagues, or reading the literature. I was particularly interested to learn about the factors that made these units successful. What were the common themes that would come out that could be applied to other centres? And I guess I had some preconceptions about what those were, but it was useful to confirm that and also learn some other things too. When I came back, I gave a number of presentations, both locally and nationally, and my friends in the government were interested to hear what we had to say as well. So the focus of my sabbatical was planned surgery, particularly in the orthopedic arena, although it wasn't limited to orthopedics. And I'm particularly interested in enhanced recovery or fast track hip and knee arthroplasty, including the new thing, which is true day case arthroplasty, which is coming on stream now. I was also interested in day surgery in a wider context, because that's something, in my opinion, the NHS Tayside has lagged behind with for a long time and really needs a focus for that. I think the COVID epidemic has put that into sharp focus. So moving fairly swiftly on, just to give you an outline of what I did on my travels, these are the UK centres that I went to, and the ones with asterisks are the ones where I actually worked as a consultant in. So the Golden Jubilee, Glasgow, Hospital for Sick Children, Glasgow, because I'm also a paediatric anaesthetist, and the day surgery unit in Torbay Hospital. I also visited Northumberland and Sunderland, which I'll come on to in a minute. As I said, I didn't want to restrict my one-off chance of sabbatical to UK, so I've got some friends in the States, so I went to Connecticut, and I went to North Carolina. You'll hear more about that later. And lastly, I was very keen to visit probably the premier centre for enhanced recovery, joint replacement, and enhanced recovery everything, actually, which is Copenhagen, which is the home of Henrik Kellett and Henrik Husted. So I went to spend a week at the hospital in Vellore. Firstly, in Glasgow, I worked there for 5 weeks, which is a nice time of year to go there. I spent 3 days a week working in the Golden Jubilee and 1 day a week at the kids' hospital. The Golden Jubilee you'll all be familiar with. Its major surgical interests are joint replacement and cardiothoracic surgery. I was particularly focusing on the joint replacement stuff because they're a high volume, low length of stay unit. And they're expanding as well, of course. I won't go through all the detail on the slide here, but there are a number of things that happen both in the patient pathway, which makes them efficient, which allows them to do consistently 4 joint replacements in 1 day, which we cannot do in Tayside at the moment, but watch this space for the future. lots of little tips and tricks to improve and refine your processes. They were one of the first units to develop enhanced recovery arthroplasty probably about 15 years ago, and they imported that from their friends in Copenhagen. And they've spread the word throughout the UK now. So lots of centres doing enhanced recovery now, variations on a theme. Their length of stay is amongst the shortest in Scotland, but not the shortest in UK. So the length of stay is about 3 days, or just around about 3 days at the moment. At the end of my visit there, I was keen to sort of consider the things that I saw there that I felt were good, and also areas that perhaps could be improved. The reason I did that was because I was invited to go back there in January and tell them about my experiences, and also give them some feedback on their own service. And I'm glad to say that I had a big turnout from the orthopedic and anaesthesia and management group, and they were very receptive to some of the points I'd made and some of the things I'd raised, which perhaps they hadn't thought about. So they found that feedback process quite useful and made some changes on the back of that. Following on from my time in Glasgow, I went to Northumberland. Why did I go to Northumberland? Well, I grew up in Newcastle, and I've got affinity with Newcastle upon Tyne, but I'd never worked professionally there. And also, there's a chap there, a guy called Professor Mike Reid, who's a professor of orthopedics there, who probably is one of the premier innovators in orthopedic service development and management in the UK. A very interesting guy who's very single-minded and very data-driven, and he's built a really excellent service in his region, which is not the university centre. It's in Northumberland, so it's a hub and spoke service with an acute hospital in Cramlington and being fed by 3 district generals. So a little bit similar to our own service with Stracathro and Perth and Ninewells. It was interesting to visit the relatively new Northumbria Specialist Emergency Care Hospital, NSEC. This is only about 4 or 5 years ago. It's based on a European or US type model with all the acute and emergency stuff going in one emergency hospital in the center of the region, rapidly being assessed, diagnosed, treated, operated on, or whatever's required, and then shipped back to the parent district general within about 48 to 72 hours, allowing the parent units to really get on with a lot of their elective work. So separating, acute and non-acute services, and this was something that was supported by NHS England, and I think from what I gather, it's a successful model. But it wasn't all work and no play. Of course, some of you may recognise the Spanish city in Whitley Bay, immortalised in one dreary Dire Straits track, which I can't remember, and they've also got a nice beach there, so managed to have some fun as well. But the unit in Northumberland under Mike Reid are about quality improvement, continuous quality improvement, and this is their length of stay after joint replacement from 2003 to 2017, and you can see the line of the trajectory of the line. They started off by visiting the Golden Jubilee, which of course I said were the first unit to develop enhanced recovery, and have continuously improved their service to the point now that they have the shortest length of stay in the UK. This is them with a length of stay for joint replacement of less than it's about 2 days. And they've also got a day case facility as well. But it's not just about length of stay, and it's not about working faster, it's about being better and safer. So when they first started, they compared 3,000 to so-called traditional pathway patients with 3,000 fast-track patients to look at the normal sort of rate of complications you might see after this type of surgery. And there was no difference in any of the normal complications between traditional and fast-track, except myocardial infarction, which was significantly lower in the fast-track group, and not surprisingly, death was also significantly lower in the fast-track group. So that was reassuring that getting patients up and about and home more quickly wasn't harmful. In fact, perhaps it was better. And also the next question is the readmission rate between the two groups different? And it wasn't. So that gave them the confidence to push on and develop from that point. Mike Reid and his colleagues are very keen on all kinds of quality improvement stuff. In fact, they contribute to the quality improvement for surgical teams website and initiative, and they teach all over the UK. And for example, they're very hot on reducing surgical site infection, which is obviously a big worry after this type of surgery. And this is a run chart of 20 different interventions to reduce surgical site infection rates, and they've got amongst the lowest in the UK as a result of that. Some of the things that I noticed that perhaps different to what we do is that they were very, very strict about theatre etiquette, about things like you weren't allowed to go in and out of theatre with different shoes on. You had to wear different scrubs in the operating room and outside the operating room. They had shoe washers for their theatre clogs and so on. There's a whole lot of things that actually is a kind of aggregation of small margins that the Sky team approach to get the outcome. And again, I won't go through this slide, but essentially they use a fairly standard enhanced recovery pathway with an enhanced recovery nurse practitioner on the ground to make sure it's being followed. Some of the things that were interesting is that they've moved away from using sedation in their patients. We use quite a lot of sedation for our patients, and they bought a subscription to Apple Music, and they bought some iPads, and all the patient can select whatever music they want to listen to during the procedure. They find that the patients like that. Obviously, it has benefits in not sedating patients. Other thing that they adopted from Scandinavia was, for the day case stuff, adjusting the way that they close wounds. So they do a triple closure system where they use a subcutaneous suture, clips, and glue. You think, why do you do all those things? Well, the reason they do those things, if they're sending patients home quickly or mobilizing them quickly, one of the commonest things that can go wrong is that the wounds leak. And this technique reduces that leakiness, reduces one particular complication. They've abandoned the use of anaesthetic rooms, and it's something else that I agree with, and that's actually speeds the process up. They have electronic prescribing with macros, an electronic medical record system, which improves standardization and consistency. And as I said, they have a day case arthroplasty service, which has been a good PR for them, and again, very popular with patients. I think day case arthroplasty will become even more popular with our patients now, post-COVID. I think patients want to be in hospital for as short a time as possible, and they've shown that in selected patients it is safe and attractive to do this kind of work. They've got a very nice patient app which is useful for giving patient information, for interacting with the patient, providing communication links with the patient, and I think these sort of devices are the future way that we can interact with our patients in a much more sophisticated way than perhaps done in the past, without being face to face. In the emergency hospital, they've got some great outcomes from their hip fracture patients, and again, they've got one of the shortest length of stay after hip fracture. A group of patients who traditionally demand quite a long hospital stay, and I just took a snap of a thing that was on the wall in the theatre, and I'm glad to say that we've adapted it or copied it for our own hip fracture guidelines. So these are simple things that can guide clinicians to think what the things that are important to do to improve outcomes and reduce variability. So the unit there, I wasn't surprised to see, had excellent clinical leadership. It had a very supportive management. The chief executive was very enthusiastic in supporting the initiatives because he'd seen so many benefits, both in terms of productivity and the way healthcare is funded in England, of course, is revenue as well. The more operations they do, the more revenue they get, and reducing length of stay and so on. So they publish their results, they share the results, they have a teaching program, they look after their staff. It was inspirational, really. Before I left the northeast of England, I went to visit a place where my dad worked here as an orthopedic surgeon, and I worked there as a porter. It's an old district general hospital, opened in 1978. But I went there because they've got an innovative regional anesthesia team, and I was keen to see that in action. But before I got across the threshold, I was surprised and perhaps reassured to see on the entrance to the hospital there's a dent in the canopy. And I'm afraid to admit to you, but don't tell anyone, that was caused by me crashing one of the large laundry lorries into that in about 1981. So there we are, still there. And but the service that they've got in the theatres there is a daily block team. They have a room and they have a roving team. So they offer regional anaesthesia blocks for all types of surgery, orthopedic surgery, general surgery, pain services as well. And it's been a massive success, and something I would really like to see established in our hospital too. It has lots of benefits, and I spent a very enjoyable couple of days with that team there. Anyway, on to the English Riviera, Torquay. All I knew about Torquay before I went there was that that Fawlty Towers Hotel was there, but it's actually very nice. Why did I go all the way down to Devon? It's a long drive, I can tell you. Well, my friend Mary Stocker was president of the British Association of Day Surgery, and she's quite inspirational leader, really, in the field of day surgery. And they do all kinds of things. When I got there, I was surprised to see how modest the hospital actually is. It's a small district general hospital in a relatively small town. Exeter is the bigger town, and Plymouth is the tertiary referral centre down the road. And I was spending a couple of weeks as a locum consultant in the day surgery unit. And it was interesting to see how cohesive and how focused that team were in doing all kinds of surgery as a day case, including emergency surgery. No barriers, very kind of can-do mentality. And, you know, it's all geared to successful day case procedures. So, for example, all patients would have a large loading dose of sustained release ibuprofen, unless there was a contraindication to that for post-op analgesia. The anaesthetic techniques were geared towards rapid recovery. There was an electronic system for automatic prescription of take-home analgesics, and a really good team of nursing staff to facilitate the whole thing, not only doing the preoperative assessment, but doing the follow-ups. Other interesting things like, traditionally, if a patient says to you, I live on my own, that would traditionally be a barrier to having the procedure done as a day case. Not in Torbay. In Torbay, the nurse will say, do you really have nobody who can come and stay with you, a friend, a relative, a neighbor? And if the answer to all those questions is no, they then offer a nurse sit service. So I said, we will send a nurse to sit with you from 10 p.m. till the following morning to make sure all is well, to facilitate you having day surgery. And so often quite elderly patients who traditionally we might have kept in hospital with all the risks associated with that can have day surgery. What they say actually, interestingly, is that 9 times out of 10, when you raise that, have that conversation with the patient, they suddenly remember somebody who can stay with them. So it's an interesting concept, but they're very focused on that. So leaving the UK, I wanted to visit the US because I've got some friends over there, and I thought it was a once in a lifetime chance to come and see some of these places. So the first place I went to was Connecticut, and then I went to North Carolina. The reason I went to Connecticut twofold. There's a place called the Connecticut Joint Replacement Institute, which I'll tell you about in a minute, in Hartford, which I was keen to see. And I also wanted to go and see my friend and roommate from university, Yogesh Kotecha, who is now a family practitioner there. That's us. We took a trip out to Rhode Island, and that's us back in the day in Glasgow, outside one of the long defunct nightclubs. I'm in disguise there, as you can see. Anyway, I had a couple of days at St. Francis Hospital. So this is basically an interesting concept, which I think is something that we could develop locally, a so-called hospital within a hospital, or unit within a hospital. So this is 2 or 3 floors within quite an elderly city hospital. So it's an arthroplasty unit within a general hospital. There's a link there that you can look at, and there's a YouTube clip which I haven't really got time to show, but that was led by an inspirational orthopedic surgeon called Steve Schutzer, who's also got a managerial head on him, who basically went with a proposal to take a team of surgeons and anaesthetists and others to basically set up a high-performing joint replacement unit in their hospital. Obviously, it's attractive to the hospital because it brings a lot of revenue to their hospital. And they've got enhanced recovery programs. They've got shortest lengths of stay in the country. And they're attracting patients from all over the place. So it's really nice for him to spend time with me, telling me about his concept and how they went about it. They've got a very innovative regional anesthesia team, and they've got techniques whereby they can provide sensory analgesia of a joint with minimal or no motor blocks. This allows patients to mobilize pain-free very rapidly. They also have access to a drug we don't have access to, which is a liposomal impregnated bupivacaine. This is called Exparel, which gives long-acting anesthesia long after a traditional dose or single shot of local anesthetic would last for. So these blocks can last for several days, which provide long-lasting analgesia. Quite expensive, about $300 an ampoule. Not available in the UK at the moment, but interesting to see it in action. The surgeons in the US traditionally work in 2 rooms and do 5 or 6 cases per day. They are robot guided. But the anesthesia was, apart from the using a different drug, was very similar. And of course, in the US, so as everywhere else, the results count. And here you see their short lengths of stay. They've got a day case or ambulatory joint replacement service as well. And unlike a lot of other units in the US, these patients tend to be discharged home rather than to a rehabilitation center. So that makes them attractive. So they're now going to centers all over the US to advise them how to set up their services. So that was Connecticut. Then I flew down to North Carolina. Why did I go to North Carolina? 2 reasons. Firstly, I've got a friend, Stuart Grant, who you'll see in a minute, who's a professor at Duke Medical Center, and also my cousin and his family, Jeff, they live in North Carolina. So it was a chance to kill 2 birds with 1 stone. You'll be familiar with Duke Medical Center. It's a huge, huge place. And again, a tertiary referral center attracting patients from all over the world, particularly for their cancer work. I was interested in their operating room and their ambulatory surgery. They've got electronic patient management systems called Epic, which is very impressive. It's very cohesive and interesting. We'd also seen that in Connecticut, and I also saw it in Copenhagen. The operating room has 36 rooms in 2 wings, so it's actually got 72 rooms plus an ambulatory unit with 9 rooms. So they've got a lot of operating rooms. North Carolina, I'm glad to say, also is famous for craft beer, and so Stuart, of course, and Jeff as well took me to some of the tap rooms to sample some of the local wares, which obviously was very important. Stuart is not just a pretty face, of course. He's one of the leading lights in regional anesthesia, and he's produced a textbook, which, if you're interested, is there. The team at Duke in anesthesiology is split into different groups. This is the regional anesthesia team. There's an obstetric team, there's an ICU team, there's a pediatric team. It's a big unit, but I spent some time with all these guys, particularly Jeff Gadsden, who's the lead. He's a Canadian. Very friendly, very welcoming, and just hung out with these guys, watch what they do. This is the Epic system in the PACU area. We put the blocks in pre-op while the patient was waiting to go into the operating room. They go into the operating room and just have this, if they were having a spinal just before the procedure. And then they come back to the PACU for a short period of time before going back to the ward. So American type system. Again, it's very efficient, no delays between patients and high productivity. I went to the ambulatory unit, which is just across the road. It was a separate building. It's got a multi-story car park next to it. It's day and 23-hour stay. The majority of the work is orthopedics, doing about 40 cases a day. Lots of it under regional. When I was obviously running around, I noticed they got a card payment system, which caught my eye, so patients can flash the cash before they go. But again, all geared to rapid turnaround. So that was my time in the States. Just to finish off the sabbatical trip, I wanted to go to Copenhagen. Copenhagen's a great city to visit if you haven't been there. And it's the home of the Lundbeck Institute of Fast Track Arthroplasty, which is Henrik Husted, his project with Checketts. And I went to the day surgery unit there. It's an academic unit. They're publishing lots of stuff in the journals. And it's a great team. I could maybe show you and see if the video will run. Just to give you a little flavor of it.
You can't see the video, Matthew. You'll have to share your screen again. want to share the video?
No nurses, no sisters
Oh, you haven't got it?
to his home.
Okay, never mind. We'll skip that. You got the slide again?
Yeah.
Okay, forget the video. It's just it was just interesting. Anyway,
if you provide me with the link, Matthew, I can put it in the comments on the YouTube channel so people can link to it if it's of interest.
Okay, I'll do that. I'll do that at the end. Okay. So this is the unit, the day surgery unit. This is the PACU area, very standard. Let's go back there. And they're doing all kinds of day surgery stuff, not just orthopedics, but the interesting thing is that when they want to do true day surgery, arthroplasty, which is what the video shows, they actually specifically put them through the day surgery unit rather than put them through the regular inpatient orthopedic ward, because they say that gives them a much higher success rate in actually getting patients home. As soon as you put them in a regular inpatient ward, sometimes they don't go home for soft reasons. The patient was feeling a bit dizzy or felt a bit sick, whereas they're much more geared to getting them home in the day surgery unit. So what were the ingredients of success for all the places I visit? I think number one is charismatic leadership and management. And these are all the people that were leading those units. I think that's crucial, with the support of management and the resources required to do it. It sounds simple, doesn't it? But it really is important. Without that single-mindedness and that drive, you're really not going to achieve that excellence that these guys have actually done. And they've built dedicated teams with a common sense of purpose. That's important. Members of the team feel valued. They have a sense of pride in what they do. They have very tightly controlled clinical pathways with minimal variation. So everyone knows what they're doing, day in, day out. It might be boring sometimes, but it's effective. But all staff are involved in continuous quality improvement. So anyone from the cleaner to the consultant can say, do you know that what we're doing is not really working very well? Why don't we try this? And the services are agile enough to actually try those changes and assess if they work or not. And that's certainly been my experience in doing quality improvement in the past. The hierarchy has to be there, but they try and make it as flat as possible. And they're very proactive in sharing outcome data with everybody. It informs, it introduces an element of competition between teams and clinicians, and instills team pride. They love it when people like me come and visit, or they're asked to give lectures or presentations. They really enjoy that, and I think that's important. One of the things that I was particularly impressed with from Mike Reed's group was that once a year he takes the group, take the whole team out, everyone, for a massive Christmas party at their own expense, from funds they've raised from giving lectures around the country. And that's a sort of thank you to the team for all their efforts, because it's quite hard to reward people in the NHS. So was the sabbatical worth it? Well, I think the answer to that is obvious. I did come back feeling different and refreshed and reinvigorated, and felt in a much more positive frame of mind about my own job. I was feeling a bit negative before I went. And I'd like to think that the experiences that I've gained, which I've skited over today very quickly, could be a massive benefit to NHS Tayside in the longer run. So I want to say a thank you to NHS Tayside for letting me do that and paying a part of my salary. And I encourage others who are thinking about a sabbatical to go for it, because it's something which I think is a very positive thing. It's something that's done very widely by our colleagues in the Antipodes, but not widely done in the UK, and it's certainly not widely done in the US either. They're very work orientated. So consider it when travel becomes easier. It's a great opportunity. So just to finish up, how could we apply some of the things that I'd seen to what our own service? Well, you heard about the CJRI, Connecticut Joint Replacement Institute. What about TJRI, Tayside Joint Replacement Institute in Perth? I think we could build a unit within a unit. We could brand it. We could build the teams. We could do large volumes of not only joint replacements, but other kinds of surgery to a high standard with low complication rate, high productivity. We could do day surgery, arthroplasty. And I'm glad to say that I've been given the task of looking at this and developing this from now in conjunction with Dave Nichol and some of the orthopedic surgeons. And I've had some very positive discussions with Pam Johnston and also with Jamie Lyon in finance today, that we can actually produce a paper to make a case to support this. So I hope this might come to fruition in the future. Ask me in a year, but we'll see. But thanks for your attention. I'm happy to take any questions. And don't forget Heaven's mixtape. I'll unshare. Stop share. Thank you.
Right. Thanks very much, Matthew. I think that was absolutely fascinating. I'm really interested in hearing what you got up to. There's one question on the chat, and I'll give opportunity for people to type in if they've got more questions, or if they're brave enough to share, to just appear on a screen. My question to you is, America, difficult place to go and work because of regulations, and have you passed your USMLE, etc. How many hoops did you have to jump through to get into the American centres, and did they treat you as staff? Could you work? What were the limitations? Were you just an observer?
Yeah,
that's all the more question, but you get my drift.
Yeah, of course. I didn't attempt to work in America because I knew that would be. I didn't need to, and I didn't want to be honest. But you'd be surprised. There was quite a lot of paperwork to go through to go to Duke. Connecticut, they weren't that bothered, but at Duke, I spent about probably 3 months filling in forms and this and that, and I had to get a login to their Duke server. I still get emails from them. But once that was all done, it wasn't that difficult. I was treated as an observer, and I got an ID badge, and it was pretty easy to move around. And I was always supervised by one of the staff guys there, so it wasn't difficult. The Danes were completely relaxed, of course, as you can imagine. And the UK centres that I did work in, obviously, I went through the normal kind of process you go for if you're applying for a job or going for a locum.
Right. Colin has asked if you can just pop in here.
Colin.
Thanks, Matthew. That was really good. Really good. I'm not sure I'm going to listen to your mixtape. I mean, I'm not going to go that far, but no, I'm joking. I'll be on it Saturday morning. But a couple of things, first of all. I think there's so much. I think many of the questions you pose about clinical leadership, about electronic prescribing, about apps with patients, we're kind of sitting on the verge of all of this stuff at the moment locally, and there's an awful lot you could pull together in a joint institute which would help that. And actually, some of those could be exemplars for taking forward things. So that's really good, because some of the questions you're posing, I think, are very answerable. The second thing was, I just wanted to make a comment about sabbaticals as a whole. I'm really pleased you've done this. I'm really pleased you've made such a success of it, because I think it's one of the ways that we can attract and sustain people as colleagues in NHS side. I think what was really good about what you did, you had real clarity about what you wanted to do, but you also did that thing of making it very difficult to refuse you. Not that I wanted to, but you really made it clear you could do a locum, you could bring some money in that way, you could pay your own way, and you chose a time of year when there was naturally some downtime anyway, as it happened. So that was really, really helpful. And just for other people thinking about sabbaticals, the more you try and answer the problems for your service, the better it is, the more likely it is to succeed. Because the key problem in the consultant contract is a line which is inverted commas, something like, if the service permits, which is a really tricky thing to get through on occasion. So I think that whole clarity you had around about it was really helpful. And I think the other thing you did, you took your colleagues along with you, and that is, in a big area like anaesthetics, is probably really important, but I think is equally important in smaller groups as well. So those were really good things. And it'd be really good if you could hook up with Elaine Henry, who's just drafting our sabbaticals policy, actually, because I think it would be really good if you could have a look at that and have a think about that, if that's an ask I could make of you. And the question I had for you was really just how many of the patients you think that we currently do arthroplasty on, let's take hips, how many of those could be fast track or day case arthroplasty as a percentage roughly?
Nearly all of them can be fast track. So the modern practice would suggest that you can get your length of stay less than 3 days to over 90% of your patients, and the median length of stay down to 2 or 1.5 days. In terms of true day case, and when we say day case, we mean go home the same day. Northumberland team and others and the Danes are saying 20-25% of patients. Hip replacement are particularly suitable. Knees are a bit harder, but they can be done. So I think, what our concept for TGRI is to start by chipping away at our existing length of stay. So at the moment, our length, about 55% of our patients go home by day 3. We can go a lot further with that. And then once you've got that really significantly lower, what happens is the team drive towards a natural reduction for everybody, and for a proportion of patients, they can be day cases. So 15-20% day case, and the rest shorter. There are a group of patients who are always going to be longer, the old and the frail and the complex. Of course, they have to be managed as well. But the vast majority can have significantly shorter lengths of stay, and with the right infrastructure to support that. So, for example, outreach teams, apps, so you can communicate with people and troubleshoot. It doesn't have any significant impact on primary care, because that's the first question people ask. Is, if you push them out too soon, they're going to be phoning up the GP or out of hours with problems. That's not how it's done, and that's not acceptable.
Thanks very much. A question in the text has been, for day case, will a traditional group matched for age and comorbidities? I suppose that's perhaps the broader question of how do you pick who's going to go for a day case procedure, or do you not quite know until you've done it?
Well, I'm not sure if that question refers to the graph I showed from Northumberland with traditional versus fast track. That was not day case. That was not day case arthroplasty at that time. That was all comers. So that wasn't matched in any way. But the actual demographics, when you looked at the paper, were very similar. So that was the first thing. As far as day case is concerned, you tend to choose obviously fitter, healthier, younger patients with some home support. It's fairly obvious, isn't it? But you'd be surprised once you start a day case service, how quickly the word gets out amongst the patients, and you get some of your older, frailer patients saying, "Oh, can I have day surgery as well?" So there's a kind of unmet need out there. So you've got to strike a balance between what's achievable and what's appropriate.
When you were talking about getting people home who are perhaps a little reluctant to it, it brought to mind something close to me, which is bronchoscopy, which is a day case procedure and should be in almost all cases. But we do have the patients who say, "Oh, I've got no one at home to look after me. I can't get home. I don't have a bus," etc., etc. And you talked about the nurse sit service. So perhaps you could elaborate a little bit more on, there's funding implications in there, and who does it? Is it a separate team, or do you just take the nurse who's on, just happen to be there and
this is in Torbay, and it's happened in other centres in England as well. I know of through BADS. I'm on BADS council now, actually, just been elected. But it's part of the day surgery team. They have a rota for night sitting nurses for this sort of eventuality, and because they think there are many benefits to patients going home the same day before you start even thinking about cost or complications. But what they do say is, when you offer that service, most of the time the patient comes up with their own solution. So it's actually the exception rather than the rule when the nurse actually has to go and do it. But if you've got that option, suddenly you'll find that sort of 10% or more patients who tell you that story, and we will keep them in, don't need to stay in anymore.
Colin, can I put you on the spot perhaps? That a comment in the tech chat here is that our commenter says, "This is really inspirational, but fear that small specialities will not be able to support, but those may be the areas where it's most important to look at improving working practices." So anaesthesia is the biggest department in the hospital, and dare I say it, they could spare Matthew, but a smaller department with only half a dozen consultants, that's more challenging. Can you perhaps talk to that?
Yeah, certainly. I think there's no one size fits all. And I think the more innovative it can be, the easier it is to land this with our service managers. I think if you're looking at a 3-month spell, you could very quickly, one of the things I'd like to do is use funding, which is endowments, to fund or part fund sabbaticals. And I think that would be really good if we could move towards that. Let's say you've got 3 months and you can cover you cover one of those months with some funding. You could find, as Matthew did, some funding from doing some local work, and you've got 3 or 4 weeks you can take. You could perhaps take as annual leave or unpaid leave, or you get other ways to fund it. So I think we probably need to be inventive to get these. We won't get a pool of money which will continually be available for us to take sabbaticals which have not of contribution to the organisation in the long term, and which allow you to go kite surfing in Iceland, but really nothing else. I think that's unlikely to be supported by any institution. But I think if we're inventive around about that, it is possible to do that. And I personally would be really keen to chat to anybody who wanted to pursue this and try and work with them. And if they come with Matthew's set of attributes where they've thought about it, got some clarity how they want to do it, and they want to figure out how we can help finance it or back cover service, I think that's important. I think the biggest problems often are that you may have a single skill which is very difficult to replace. When Ron Mountain took his sabbatical, what he did was, rather than work for 3 months, he worked for 6 months part-time. So he basically took an in-house sabbatical, taking half of a week off doing sabbatical things for 6 months, which allowed him to continue his clinical commitments which other people couldn't cover. So that's the sort of flexibility and inventiveness I think we need to think about.
Excellent. I was completely unaware of the time frame, 10 years in, 3 months, etc. And although I look like a spring chicken, I'm in my 11th year, so that means I could, that's very interesting that 3 months is on the table. Thumbs up for Matthew. Does anyone else have any comments they'd like to make before we round things up? Okay, well, thanks very much, Matthew. I think that was really fascinating stuff, and if anyone does go on a sabbatical, particularly traveling the world to find these things, I'd really welcome them to come back to Grand Rounds and present, because that's just really fascinating stuff, and it's well below the diaphragm. So I know nothing about any of that, and it's great CPD if nothing else. I'm fascinated by it. Next week we have 2 Grand Rounds. What we're going to have is the postgraduate team, along with the DME, are going to speak about what does training look like from August. And then on the Friday at 1 o'clock, we're going to have the undergraduate team. We're going to talk about what does undergraduate training look like from September. They can't quite marry up to be at the same time. So 2 separate Grand Rounds on 2 separate days, but it's the same deal. So I'll send around 2 different Zoom meeting links when I can. Thanks again to Matthew. Thanks for all of you coming along. I will put this on YouTube when I've got some time, and enjoy the rest of your day. Thanks very much.
Enjoy the show. Mixcloud.
Oh, yes, Mixcloud, everyone. All right, take care, everyone. Bye.
Bye-bye. Thanks for having me.